Very good day, my dear postgraduate students. I wish to take you to recent advance 16. I hope you people are in the near vicinity of such. I would like to thank my colleague and the students from Andhra Pradesh who had provided me with the copies of these. The dictum is that whatever be the topic in a recent advance, I should be prepared with it for the exam. The topic for the day is pathology of death in pregnancy by Toner and Crane. Now, a topic like this, look at the index that I have prepared. Rather, it was there in the article itself. There is a list on my left and another on my right also. I have given it a different color. And there are various terminologies which would best fit in to a community medicine or a community obstetrics. So these terms we people should be familiar with, as I always used to say. The greener tinge actually indicates the role of a pathologist in such situations. So the topic appears seemingly very simple, but to my knowledge, extremely complicated. Let us see how best we can unravel this. I don't know where I am going from here, but I promise it won't be boring. Not my words, David Bold. There are a few terms that we should understand. Death during pregnancy or within 42 days of delivery is one that comes under the obstetric complication. Abortion, it can be maternal or it can be an obstetric death. Obstetric complications of pregnancy during labor or puerperium. And any form of intervention, omission, or incorrect treatment directly connected with obstetric deaths. So these are some of the direct causes of death during delivery. Whereas after 43 days to 1 year, it is considered to be a late death. There are some indirect causes also. The disease predated or first occurred during pregnancy, but not due to any obstetric cause. We shall see what it is. Indirect obstetric deaths. And fortuitous, which means death from other causes during pregnancy or puerperium. So these terminologies I would like you people to kindly register in your minds, not by heart. The terms again continue. Substandard care. It is a failure in the clinical care as such. And as a pathologist, you might have to give such a report. Identifiable adverse factors and confidential inquiry, establishing the cause and also understanding it. These were all terms which was brought in by this National Health Service administrative channels in the UK. And they had dealt or studied the maternal deaths in England, Wales, and the other countries around. And finally, they have proposed such terminologies which have stood the test of time. This is a fairly decent table picked up from elsewhere, the research kit, which fits in with our lesson. The death due to obstetrics or maternal death can be direct or indirect. And direct will be these kind of causes which we shall try to touch upon in the text. And also there will be indirect causes, which again we shall be mentioning on and off. This particular list I would like you people to kindly remember, because this superimposed on your knowledge of general pathology, I think you will be able to answer the question quite easily. Thrombosis and embolism. Look at my word over here, province. So obviously we will have to go to, or rather have a good knowledge of the general pathology, the circulatory disturbances. Many a time we find that the smaller emboli are overlooked. They cannot be traced. They can occur during various periods, not necessarily during delivery alone. In a cesarean section, also they can be associated with leg vein thrombosis, resulting in the cerebral venous embolism, or sadly we find in 2% of cases there can be arterial embolism. The precipitating factors in such thrombosis and embolism are, as you all know, immobilization. Surgery, any major surgery can be there. Obesity of the patient and age. So very simple, very common. So I will not be going too much into the details of. In fact, look at this box. They are all similar to the non-maternal causes. Thrombosis and embolism. Hypertensive disorders of pregnancy. Always you would have tried to become a obstetrician. And then you know that there is always a complication of pregnancy in the form of hypertension or diabetes and so on. There can be a preeclampsia, fits and eclampsia. This is associated with direct maternal deaths, which can be because of DAC, disseminated intravascular coagulation. 2. There can be a cerebral hemorrhage, necrosis, edema. ARDS, adult respiratory distress syndrome. Pulmonary hemorrhage, edema, and a bronchopneumonia being superimposed on them. Hepatorenal failure. These are things which are quite common, but then the list is mandatory. I will not be repeating it. Kindly go through it. Every word is important. Then there is a HELP syndrome. Hemolysis, elevated liver enzymes, and low platelet count. Hypertensive disorders of pregnancy, again I'm continuing. In this one, obviously the patient is death, we are dealing with death or an autopsy. Therefore, examination of all organs are mandatory. Look for arteriolosclerosis. Preeclampsia complicates hypertension, and there can be any other chronic renal disease also. There can be the fibrinoid necrosis of the blood vessels, as you people are seeing over here. In the media, there is a homogeneous eosinophilic material that is there. Another term is atherosclerosis. We shall see what it is. And in the liver, there can be periportal hemorrhage. So, what are all the various organs? What can be the changes in a case of hypertension? And what is this atherosclerosis? It is a maternal vascular lesion caused by preeclampsia and idiopathic uterine growth retardation. In any of this, there can be atherosclerosis. There is a vascular occlusion, different from atherosclerosis. And in this, there is a vasculopathy. There can be a fibrinoid necrosis. Along with that, there can be accumulation of lipid and mononuclear inflammatory. Almost similar to the fibrinoid necrosis, kindly mention this too. Ectopic pregnancy and abortion. Repeatedly, I think we people are diagnosing this ectopic pregnancy, confirming it, and so on. So there is a lot of statistics. We will not be going into it. Look for the tubal damage or rupture. And it is said that the distal 2/3 of it, look at this region, probably this is a distal 2/3, this is more commonly involved. And any other form of sterilization must be histologically confirmed. And this ectopic also, you'll have to look for the villi or the decidua and then confirm it histologically before giving a diagnosis. Any illegal abortion will have to be ruled out history-wise as well as with other findings. Air and walls. Cervical laceration, shock, sepsis, and asthmatic attack because of drugs. So look at the things that can happen in this. Ectopic pregnancy. It appears very simple, but nobody expected such a plethora of terminologies to be under it. So obviously there is life outside the pelvis. Where I mean, there can be a shock, there can be an asthmatic attack, and so on. The hemorrhage again can be antepartum causes, placental abruption, placenta previa, and postpartum, instrumentation, cesarean, DAC, etc. So you'll have to confirm the position of the placenta and whether there is any edema, rupture of the maternal decidual artery. And you'll also have to look for any retained placental tissue. Any retained tissue, even if it is the patient's womb, will be acting as a foreign. So this is all life within the pelvis. Certain things we saw outside, and this is purely the pelvic property. Amniotic fluid embolism. Those days we used to get a slide of this. Epithelial squamous, Lanago hair, meconium, vernix, mucin. And obviously it's along with the interstitial congestion. So it can occur in the pulmonary artery and the capillaries. And another picture of the same. Thanks to Wikipedia and forensic pathology for these pictures. Amniotic fluid embolism is 8 times more common than the other causes. It can lead to, what is the cause of this amniotic fluid embolism? Very rarely it will lead to a mechanical obstruction, but mostly the cause of death is respiratory distress, dyspnea and cyanosis, disseminated intravascular coagulation, acute vasoconstriction of the pulmonary arteries. Thanks to Robbins, go back, read your circulatory disturbances. This can happen in cases of prolonged labor, increased maternal age, and sometimes there is no relation between the severity and the size of the particles. That is why, for example, in DAC, the size of the particle is not important at all. And in vivo, clinical test is needed. So you'll have to do a fibrin degradation product, etc. Genital tract trauma. So in this case, what happens is there has been a previous cesarean. There is a scar, and obviously there is a chance of a rupture along the scar. And this people know. We used to call it a CPT, complete perineal tear. It can be anterior, posterior, whatsoever. So look for the vaginal, cervical, and the uterine tears. And also sepsis is another thing. The infections can be because of various organisms. I just mentioned a few. Beta hemolytic streptococcus, E. coli, staphylococcus, and any form of septicemia can result in again ARDS, DAC, endometritis. So you find that these causes are repeatedly interlinked. Anesthetic deaths. So there is something, it is like a shadow or a ghost. And sometimes we search for it, we will not be able to find it. It can be because of a misplaced endotracheal. Gastric contents, there is an aspiration. And during a spinal anesthesia, it is possible. There is one syndrome called as Mendelssohn syndrome, named after an American obstetrician as well as a cardiologist, Curtis Mendelssohn, who is the first person to describe it. In this one, there is a kind of a bronchopneumonia that is developing due to an aspiration, desquamation, necrosis, neutrophils, hemorrhage, and there can be cardiac failure in cases of valvular disease. So Mendelssohn syndrome we'll have to mention, and the other anesthetic complications. This is from the United States, pregnancy-related deaths. Almost it is similar. Only thing there is a cardiomyopathy that has been included, so we'll have to look for all these things. infection, hemorrhage, coronary conditions, preeclampsia, embolism, all are there. Thanks to social justice platform US. Massive pulmonary emboli. Again, go back to the circulatory disturbances. Emboli can be of three types. One, it is very massive, so that there is a sudden death. And when you look for any changes, it will not be there, only the embolus will be there. No infarction. Second one will be, there will be in the medium-sized blood vessels. But when it is going to be gradual, there is chance for a collateral circulation to develop, circumvent the obstruction. The third one will be in the smaller end arteries or the towards the periphery. And this is definitely going to cause an infarction, which we will have to look for. Now, this is a case of a massive pulmonary embolism, saddle embolus, for example, in a bedridden patient. And thanks to this particular reference for this wonderful picture, American Heart Association. Ruptured ectopic. I've already shown you a picture. You find that it is more common in the ampullary region, fimbrial region. The distal two-thirds is most common over here. Rupture can occur on the other side, cervical, or it can occur in the body in a cesarean section. And others, obstetric hemorrhage, postpartum cardiomyopathy, embolism, eclampsia, and complications of surgery, etc. will have to be borne in mind. This already we have seen in our placental examination. So what are the placental anomalies? One is, so there is a uterus over here, there is a cervix, the vagina, there is a serosa, the myometrium and the endometrium. The normal placenta, you find that it is a kind of an attachment and then there is a cord that we are seeing. It is just very snugly opposed to the uterine wall. Placenta increta, there is an increased intrudence into the uterine wall. Placenta previa is, it comes before the fetus itself, causing a kind of an obstruction. And percreta is, it is almost like an invasion passing through and through. And accreta is, again, a firm addition, so that when there is going to be a delivery, obviously there is going to be a rupture and hemorrhage. So these are some placental anomalies that we will have to bear in mind, not that we are obstetricians. And the various abnormalities also, succenturate, there is an accessory placenta over here, circumvallate. So the placenta ends over here and there is a huge membranous area that is surrounding it. Filamentous. So you find that the placenta, it is supposed to be covered by the membrane. The cord itself is free of the membrane. But in this case, the membrane, it goes into the cord also. And battledore is another abnormality, wherein there is a circumvention of the whole thing. So these are some of the abnormalities we have already dealt with in placental pathology. Kindly go back to it. ARDS, one of the most common causes. Any disease, remember DIC, ARDS. There can be diffuse alveolar damage, injury to the endothelium, and the alveolar epithelium by the neutrophils. Edema, hyaline membrane can be formed. So this is one thing that I would like you people to kindly follow. A fantastic picture from pathology outlines. See what is over here. Please follow my class deliberately. So normal alveolus is over here, and in this I am able to see the lining epithelium of the terminal bronchiole. There is a type 1 cell. Lower down there is a type 2 pneumocyte. There is an alveolar macrophage. Then there is a small bit of interstitium and the alveolar capillary is over here. This is normal. But see what is happening over here. In case of an injured alveolus, so there is a protein-rich fluid that is getting accumulated. The epithelium is getting sloughed off. When in doubt, compare. So you get a necrotic apoptotic cell compared with the live one. And there is also the intravasation of the RBCs into the alveolar spaces. There is the classical hyaline membrane that can be formed, that can be the deposition of fibrin. Various mediators can be produced by the neutrophils as well as by the macrophages. The same thing is happening over here. So there is increase in the thickness, interleukin is being produced, and the mediators, see what are all the changes. And this is the case of chemotaxis that is happening. So please remember this particular. The gross picture in an ARDS. So obviously it is not liver-like, but more consolidated. And I'm finding a purplish tinge in this lung, heavy and boggy. And obviously when you try to compress, there will be a frothy fluid that comes out of it. Dull, poorly aerated, and blood-stained alveolar fluid will be there. And histologically, what we had seen earlier. There can be hyaline membrane, fibroblast, interstitial edema, and a bronchopneumonia. So this is a gross picture. Other direct causes. What are the other organs which can be affected? This is one. I hope you people are able to identify the central vein of the liver, and there are some pale cells over here which are having multiple vacuoles. Microvesicular fatty liver of pregnancy. And the fatty chain is surrounded by the normal ones. In some areas, I am able to see the normal hepatocytes. There can be a jaundice, maybe a hepatic jaundice. There can be a DAC. Always DAC is your God in the sense. Pseudomembranous colitis and neurological also, but it is not confirmed. So these can be the other causes, pseudomembranous colitis and neurological. Now, what about the autopsy? It has to be done by a competent and an experienced pathologist. Laboratory tests, of course, are very important. And there has to be the examination of the various organs, as I had mentioned. There also should be a correlation to come to the final cause of death. Coroner or the procurator's physical is also essential. The pathologist can do a restricted autopsy only when the unnatural causes are eliminated. Otherwise, a general autopsy, an open autopsy is mandatory. Controversial. Sometimes since it is maternal, it is socially sensitive and people may not be agreeing, but sometimes it is mandatory for us to find out the cause of death. The death itself can be direct, indirect, or sometimes it can be coincidental. And these are the definitions. Direct means directly related to the pregnancy. Indirect means diseases not related to pregnancy. And coincidental is disease which are totally unrelated but happens at the time of delivery. The examples are given over here, eclampsia or the amniotic fluid. In this case, indirect. Look at this one, aortic dissection, valvular diseases of the heart. And coincidental, homicide, collision or an accident, cancers, etc. Indirect will be this. Again, it's a repetition. I would like you people to kindly go through this. Fortuitous, other non-obstetric causes that occur in late pregnancy. For example, it can be a choriocarcinoma, sepsis. Only thing, late deaths will be beyond 42 days. 43 days to 1 year is called as late death. So you need the assistance of a specialist for complex data. In this always, it is not a pathologist alone who is making a final diagnosis. You need the role of an obstetrician, the anesthetist to find out the probable cause of death. Example, what can we do in a case of a tension pneumothorax or an air embolism? External examination as usual. So the genital tract is more important and we'll have to rule out all the other causes. Only thing when we are opening up, the neck veins must not be open. The rib cage, pericardium, ventricle are all opened underwater to rule out a pneumothorax. Cerebral vessels will have to be done under dubious conditions. So these are things which you'll have to remember. Tension pneumothorax, air embolism and genital tract trauma. Genital tract trauma. A detailed examination of the lung and the parametrium. Any tears in the uterus, cervix or the vagina. And removal of the female genital tract, incision, vagina to anus. This has to be done so as to find out any abnormality in the intervening region. Symphysis pubis will have to be cut and the female genital tract will have to be removed intact. This is important. This is not given any kind of a significance in the routine autopsies. Swab, cervix and vagina will have to be studied for infection. Also look for any recent or old injury, eclampsia or hypertension, fallopian tubes for ectopic and any other surgical procedure. placenta and the dead fetus will have to be obtained and studied. Examination of the cardiovascular system and respiratory. This is a routine, of course. You'll have to rule out a hypertension, cardiomyopathy, septal defect. In the lung, any of the infections, amniotic fluid embolism, a pneumothorax, saddle embolus, etc. Gastric contents because of the aspiration. Alimentary tract, any bowel injury, dilatation, liver for hemorrhage, and the trauma to the bladder, kidney, etc. Again comes disseminated intravascular coagulation. So what I would suggest is you have the list of the organs. It is all quite easy. And at least 1 or 2 points for each of the organs which we can recover. And histological examination is definitely important. But usually these are lacking in a maternal autopsy. For example, how do you diagnose a hyaline membrane disease? How do you diagnose an embolism in the glomerulus? Unless we do a stain for the fat. So availability of the tissue should be mentioned. There are some special stains also. I'll just show a few pictures over here. H&E, of course, we people know. This is one stain. Colors are the smiles of nature, later. So this is one we had already seen. It's a forensic pathology picture. Courtesy. Look at this beautiful one. It is called as Martius scarlet blue staining. And in this, there is the embolus which can be traced very easily. In this Martius scarlet. So the red and the blue, they contradict or contrast. This is another one. Earlier also I had shown you this picture. You people will have to see what are all the various mediators which can be produced, what is the cytokine storm within the alveolus, and that leads to the various pathology. You can make use of this for any other answers. The examination of the placenta, again I have covered it. It should not be disposed of. And then the cord, the membranes, the abnormal placenta, premature placental separation, hemorrhage, etc. will have to be studied and ruled out. Additional investigations will be the swab and other things, whether the patient has got a generalized disorder such as a convulsion, etc. And intoxication of the other things. And a thorough knowledge of this basal plate and the intervillous surface is needed, and this has to be studied in detail. The anesthetic test, it can be difficult for the pathologist to explain, biochemical or toxicological. It can be because of oxygenation, intubation, misplaced needle, aspiration of the gastric contents. These are all some of the anesthetic things. So the conclusion is that pathologist, of course, has got a key role, but he is not the only person. It has to be done in relationship with the group such as the obstetrician, the anesthetist. And autopsy alone cannot resolve all the problems. And organic and anatomical evidence will be needed. Anesthetic deaths are usually inconclusive, and negative findings lead to the possible cause of death with unexpected pathological findings. So sometimes we may find things that we are not looking for. So we must all display the sequence of events in an order and not avoid them. Endings to be useful must be inconclusive. Thank you.